Join me to welcome our moderator, Professor Francis Seow-Choen, Medical Director of Seow-Choen Colorectal Cancer, Singapore.
Thank you very much. We want to get seated here because we are here now for the next keynote lecture 2, which is given by Professor Arun Rojanasakul. Of course, I don't think we need to introduce here in Thailand, but anyway, he is the Professor, Colorectal Surgery Division, Department of Surgery, CHULALONGKORN University, also now practicing almost full-time at Bumrungrad International Hospital in Bangkok, Thailand. Also, Professor Arun, I've known him for about 30 years. And he looks the same yesterday, today, and tomorrow. And he's an avid collector of seashells, still, Arun. Tells me he keeps all his precious seashells below his bed.
Correct.
Yeah, so Professor Arun, we are looking forward to hearing you speak on pelvic floor anatomy. And I'm sure all of us will be very well educated after that. Thank you very much.
Thank you, Francis, for your introduction. Good afternoon, ladies and gentlemen. I would like to talk about the anatomy again, but I think it's not new. This I have lecture. I have given the lecture many times before, but as I told you, when you listen to my anatomy the first time, you can understand only maybe 50% or less than that. And you listen to me the second time, you can understand maybe only 60. But if you listen to me the third time, maybe you understand maybe 70. You can understand all if you sit down with me and ask questions with me. So that to be the fellow in colorectal surgery you are, and you can understand more. Otherwise, you cannot fully understand. Difficult one. However, I try to make it very simple for you to understand. It's not all the anatomy of the pelvic floor. It's part of it, but it's some important part of the pelvic floor anatomy. But it's not related to the surgery, colon surgery, but it relates to the pelvic floor surgery. It's relation. Some question. When you look at this, pelvic floor is the same as pelvic diaphragm, or is it the same as elevator ANI? Is it the same? I think you think that it's the same, and I agree that it's the same. But look at this. Pelvic floor descent is a perineal descent, but pelvic floor is perineum is question, and pelvic floor diaphragm. Pelvic floor equal to pelvic floor diaphragm. And then perineum equal to pelvic diaphragm. You start confusing. Because perineum, in fact, is the area under the pelvic diaphragm. It is not. So, in my presentation, I will tell you that the muscle and the vessel and the nerve in this area, all in this area, is the pelvic floor. Is the pelvic floor. It means that if you have descent perineum or descent pelvic floor, all of these organs descend together. So I try to popularize this understanding. The anogenital muscle complex. There are 3 level concepts. I use this concept with the pelvic floor and with the fistula as well. So maybe tomorrow you can see this again. This is the 3 level. The upper level, the middle level, and the lower level of the muscle in this area. Okay, let's go to the upper level. The levator ANI. The levator ANI attached anteriorly to the pelvic bone. One send from the symphysis under the lower limb of the pelvic bone, and then go to arcus tendinous, and then go to the coccyx, and then go to the coccyx, and the sarcum, distal sarcum, which means that levator ANI is it can be named puborectalis, pubococcygeus, iliococcygeus. But this T muscle, in fact, is one muscle. It's a continuation. And you can say the name only by location. By location, it means the outermost is the iliococcygeus. But in fact, levator ANI, the inner part is the puborectalis. It's a funnel shape. So, I already tell you the attachment. If I say puborectalis attached to the coccyx, no one says, hey, no. Puborectalis is the loop around the anus. Right? But when during any dissection, if you pull the levator, if you pull the puborectalis, only the puborectalis, at the rectum, the tension is at the coccyx. So, puborectalis attached to the coccyx. You understand? And this is have clinical implication, I tell you later. Go to the second level. The second level in the posterior around the rectum is the superficial external sphincter. It extends posteriorly and become the anococcygeal ligament and attached to the coccyx. This is not anococcygeal raphe. We always mix. This is anococcygeal ligament. Raphe is up above the sacrum. Maybe raphe above the levator. But anococcygeal ligament there. And anterior to the superficial is the superficial transverse perineum. And in anatomy dissection, this is the key muscle, superficial transverse perineum. If you want to dissect, to show any muscle, you must look at this muscle, is the key. And then anterior to the super transverse perineum is a thin membrane. It's called the deep transverse perineum or perineum membrane, just below the levator ANI. And the lower one is the subcutaneous and the bulbouscoinosis. So there are three layers like this. And when, if you have descent perineum, all of these descend, all of these weaken and drop down all together. During the defecation, Francis has shown, Dr. Guo, MI, everything widening and drop together and contract together. This is T level that I told you in the anal region. There are levator ANI. It cannot separate into many T muscle, but in fact it's a continuation of muscle covered by single fascia. And you have superficial external sphincter and subcutaneous external sphincter. Even in the nectar, you have T muscle, the same, but you call differently. Anatomy never changed, but we call it different, that's all. Then we will talk a little bit about three things that I would like to address. One is the levator ANI. Is T separate muscle or is a single muscle? Second, the ligament in the pelvic organ. Is it a true ligament or is it a fascia? The third one is the rectal vaginal septum fascia. Is it present or absent? I will focus about this. If you look at the levator ANI in Wikipedia, you can say that the puborectalis, pubococcygeus, is iliococcygeus. You can see in the other description like this, you have T muscle. But in our dissection, in our cross-section like this, it's only continuous muscle. It's only one muscle. So this picture is the old picture. If we detach all the pelvic floor muscle from the bone, if we cut it out, just cut it out, it comes this picture. Just cut it out. And then this is the levator ANI covered with the fascia. The fascia is still intact. And if we remove the fascia, we have the red levator ani. It's very thick. In fact, it's not thick. It's only 1 millimeter in thickness, or nearly to 1 millimeter in thickness, not thick. Under that is the ischial fat. So it seems bulging, but in fact it's thin muscle. But this muscle is continuous layer. You can see superficial egg hidden inside and subcutaneous below. So we go to levator ani is one muscle. Then we go to the next topic. It's a laxity of pelvic organ, suspensory ligament, cause pelvic organ and perineum. They said that suspensory ligament, it means the pelvic organ ligament. So it's 2 ligaments. I show you the ligament. If we cut the pelvis, we can see pubic bone, we can see bladder, vagina, rectum, and cecum like this. You can see like this. And if we look at the bladder first, you can see some attachment. And we call attachment, maybe someone call ligament. Median pubovesical ligament, lateral pubovesical ligament, fascia to the uterus and uterosacral fascia. Don't worry. Sometimes you get confusing, don't worry, just follow. So for the uterus, you have ball ligament, round ligament go into inguinal canal, and you have a round ligament, and you have cardinal ligament on the lateral. Cardinal ligament continue from the uterosacral ligament, like this, the uterus, the rectum. And maybe this picture is difficult to understand. I show all the ligament. Bladder, uterus, rectum, cardinal ligament. Go to the rectum. We are familiar with rectosacral fascia. Rectosacral fascia, in my understanding, is from the levator, it fold up. And for the lateral ligament, in the lateral stalk, we have lateral stalk. We call ligament. So in the rectum, we call stalk, not like a ligament in the uterus. But this is the key picture. That solves all the question. This is the key picture. I spent with this picture for a longer time. When we peel out the fascia of the levator ani, we can see that the arterial supply go to the bladder, go to the uterus, and go to the rectum, like this. And this is what they call ligament. This area they call ligament. If this area covered by the fascia from the levator ani, so no true ligament at all. No ligament, just the fascia that cover the vessel. So in the clinical practice, we cannot repair uterosacral ligament. We cannot. And we cannot repair cardinal ligament. Cannot. If we repair, it means that we just suture the artery. And it will fail. So the surgical technique that designed to suture this ligament is not correct. We cannot repair this because this ligament, in fact, is just an artery and vessel, and nerve around the vessel. So suspended ligament of the pelvic organ are artery and nerve supply of the pelvic organ, which are covered with the superior fascia. So the theory that because of weakening of the suspensory ligament and cause pelvic floor descent is not correct. This theory is not correct. Maybe it's just weaken of the muscle. I think that's correct. Or weaken the muscle, the pelvic floor muscle, and at the same time, the fascia that cover the muscle. It's not weaken of the ligament. Now we come to the last one that I want to share because we have limited time. Rectovaginal septum. Are there rectovaginal septum fascia? It's still controversy. This picture, I cut like this and show the rectum. And then I put a light in the vagina. You can see rectovaginal septum very thin, very thin. It's very thin. I just cut to the rectovaginal septum. You can see the vagina and rectum above. I cut it. And then I would like you to see this. When I magnify this area, we can see the longitudinal muscle because I trace it upwards and it join to the longitudinal muscle. And you can see external sphincter, internal sphincter, but I cannot see some fascia. Maybe, I do not know, maybe what they call rectovaginal fascia. Most authors said that rectovaginal septum fascia is the denonvillarius. But in man, denonvillarius separate the rectum from the genital organ. In women, the rectum and vagina is a coega, and the genital organ is above, is in front. So, what we call the denonvillarius should be anterior to the vagina, not in the middle. Should be anterior to the vagina. It's the same. Man and woman is the same. So, we will try to see. In this picture, you can see the fascia of the levator. This is the levator. You have pointer? No. This is, you can see the levator over there. You can see. And you can see the white tissue. White tissue. You can see the white tissue? No. The white tissue here, above the levator. And you can see the rectum. Because we cut like this, the rectum like this, and we can see the vagina. We will go between the rectum and the vagina. We will go in between. Okay, maybe like. If we go in between, this is the vagina, this is the rectum. And you can see the levator here, and you can see the fascia here. Because the levator do not go into between rectum and vagina. The levator do not go in there. So the fascia do not go. The fascia come here. This is the fascia of the levator. But as I told you, fascia of the levator become the denonvillarius. It's the continuous become the denonvillarius. You may not know. One they say this is the denonvillarius. Yes, in male, between the rectum and the seminical. I said, where it come from? They said, I don't know. So follow it. If you follow it, the denonvillarius is a superficial. It's the superior fascia of the levator. This is its muscle, become the denonvillarius when it go anterior to the vagina. Okay, so in this picture, I conclude that there are no rectovaginal septum fascia. So any technique that try to repair this fascia is not correct. There are some technique, many techniques that try to repair this fascia in the literature. It's not correct because it does not exist. It means that you just repair longitudinal muscle. So for the take-home message, the arterial is difficult to understand. Sorry, I should bring the picture up, but I do not. The ligament is not to recommend, and the rectovaginal septum fascia cannot identify in my dissection. And thank you for.
Thank you very much, Professor Arun. That was very clear. And I think everybody understood you, so nobody's going to have tea with you to ask you more questions.
Thank you, thank you.
So anyway, I think this is a keynote address, right? So there's no questions for you also. Okay. We will go now straight to the next lecture, which is going to be given by Professor Shuqing. She's going to talk about multidisciplinary theme in obstructive defecation syndrome, pelvic floor center experience from China. And she's giving the keynote lecture 3. Professor Su comes from a long line of Chinese traditional medicine practitioners. I think she's the 10th generation in Nanjing. 10. her father is currently still the medical director of the Nanjing Traditional Chinese Medicine Colorectal Hospital. So I'm sure she'll give us insights after that thunderous announcement. So let's welcome Professor Ting to come and share with us her insights on pelvic floor experience from China.
Okay, I'm sorry. Thank you. Today afternoon, I want to share some work of my pelvic floor center. I'm from China. Today, the topic is MDT in ODS from our experience. Today, the outline is I want to show you from the 5 categories. So let me see that what's the key of the multidisciplinary teamwork. So that's 5 W. So firstly, that we need to have a very clear flow chart. That's the timing and how to do it. And the second, that's high technique, how to use it, and how to manage it. And then we need to have some integrated theory of the idea from body and mind, also from east to west, from health to wellness, and from traditional to update. Actually, we need test the cost-effective analysis. That's from the evidence-based medicine. So actually, we need a team in a true pelvic floor center to do this work. Okay, what is the ODS? Actually, we can from these 2 pictures, we know that's it's very easy to understand. Like we need to have the efficient rectal pressure, and at the same time, the anal muscle should relax. So this is normal. But if it not coordinate, there will have 4 subsets of the dysnergic defecation. That's the ODS. So from our research, that the type 1, that's paradoxical muscle, that's mostly in nearly 50%. And then we turn to that why ODS needs MDT, because usually from the female, from the different stages, we have from different manifestations, pregnancy, after childbirth, menopause, and elderly. So actually, in this clinical, in our pelvic floor center, mostly that's a functional constipation. So, but the ODS shares 83.4%. Actually, most of the patients also at the same time have many symptoms, mostly from the psychological and the psychiatric issues, and from the upper GI symptoms, and other chronic disease such as hysterectomy, after hysterectomy, also lower rectal cancer, operation also from the obesity, diabetes, and COPD, etc. So we have very difficult patients, not only from the superficial symptoms of the ODS, maybe at the same time, patient has constipation, fecal incontinence, pelvic floor pain, and POP, the prolapse, urinary incontinence. So for a patient, there is a very difficult to, only for the constipation to treat. Otherwise, that's ODS, that's like the, because it's imbalanced systems, so we'll have overlapping symptoms. We can see just from the different symptoms, from muscle system. From muscle system, we can to know from the manometry, from the from the surface EMG, we can discriminate how to hyper, or just dysfunction or paradoxical. And from the nerve system, we can see maybe from the pudendal nerve, sacral nerve plaques, or something from the ligament dysfunction, mostly from the USL and PUL for the posterior compartment. And otherwise, that's from the bone, from the maxilla, and from the brain-gut bacterial axons. Otherwise, from other many theories, so it's very, very difficult to know the ODS, what's the etiologies. So that's why in our clinical practice, we only to see the tip of the iceberg. Then we know that pelvic floor center is our a very good platform to standardize this technology and train the team's skills, also to optimize the clinical pathway. That's where we have the 3 keys. One is a flow chart. The other is how many key techniques in your pelvic floor center. And then we need teams to do these things. As for the flow chart, I will go through later. And as for the key techniques, that's the team leaders make the decision for the people, for the patient, to the individual strategies for very difficult cases. We need from the Western diagnosis system, we need finish the symptoms from anterior, middle, or posterior compartment. And for the diaphragm, barium, ultrasound, or MRI, we need know that's what's the morphology. Also, we need some functional diagnosis from the manometry, transit time, urodynamics, or physiology tests, etc. And then we need to see, let the patient to finish the questionnaires to see what the details of the symptoms and the very complicated history collecting. Otherwise, we need the digital examination to compare this. Also, we need the psychological questionnaires to see the severity and the quality of life. Also, we need the patient-reported outcome to testing to evaluate the results. And actually, the pelvic floor center, that's the multidisciplinary models. It is the integration platform for clinical research and education, also for the administration. In this platform, we can finish all the treatment in this platform, from the prevention to diagnosis to treatment, from the non-surgical to the minimum invasive surgery. Okay, let's go to see how to organize the team members. In the pelvic floor center, we need to optimize the clinical pathway from the colorectal, gastrointestinal, urology, radiology, rehabilitation, gynecology, psychological. Also, because of our traditional Chinese medicine and acupuncture also has very good results. So we need so many things to come together. But how to optimize this work? We need a very good leader to organize. And biofeedback therapist is the key to finish this work, treatment work. Also, we need acupuncturist, nurse, and research fellows, etc. Some of the team members as full-time, some of that's part-time job. So let's see the flow chart. Firstly, we need to let the patient to have the cognitive therapy and let them know that how this, the symptoms and how the reasons. The patient can by lecture, by video, by social medias. Also, we need to let the patient have some training at home for the long-term results. Actually, for the balloon sensation training device or some self-enema device at home. The second, we can use the herbal medicine. That's the second step, because herbal medicine patient needn't to come to the clinic very often. Actually, we from the patients, mostly patient has a catheteric abuse patient. So a patient need some some herbal medicine to change the constitution. Mostly patient have the combined irritable bowel syndrome symptoms. So the patients have the warming herb formula of our research. Mostly 60% of the patients got the recovery. So this is the formulas. Then the third methodology is the biofeedback. Because biofeedback therapy, the success rate actually is high, but we need to think about what's the best indication, need patient education, and a good therapist, good protocol, and good equipment. Otherwise, we need to consider the insurance cover, treatment course, convenience, also the marketing orientation, something like this. So we need integrated treatment effectively. It is more than 70%. And at the same time, because biofeedback need the patient have a very good compliance. So otherwise, patient no compliance, we can use acupuncture, but they still, patient have to come to the clinic very often. We do the acupuncture sacral nerve modulation, use the long needle techniques to insert into the sacral volume. That's have a good methodology. Also, we can use acupuncture to modulate the central nerve stimulation, ANS and ENS at the same time. Also, we can integrate treatment with the biofeedback that will be effective, micro-invasive, and inexpensive. And the fourth step, we can use the Botox injection with the biofeedback. We use the needle EMG guiding to inject the Botox into the puborectal muscle or the levator muscle. The timing, actually we have more than 100 patients experience. We think mostly that's after the biofeedback failed the patients. And then we follow the short-term results and the long-term results. We found that's the indication, the best indication. That's our experience. That's not published now. Indication is that the type 1 dysnergic defecation, also patient need to have the normal rectal sensation and compliance. Then this kind of patient will have the best indication for the for the Botox injection. And after that, if we need to have a long-term result, we need to use combined with biofeedback. And the 5 steps that we need customized, tailored surgery. The tailored surgery, actually for the dysnergic defecation, that's almost none because we can use biofeedback, we can use a Botox injection, nearly no cutting or cutting the muscles. And only for the interception, we need very consideration to see is the reason or result. If only the interception, almost none for the operation. For the rectal seal, we need to see that rectal seal with interception, if the conservative is not very good, conservative therapy is not very good, we can do the surgery. Like surgery, how can we do? We can do the plication and reconstruction for what? For levator anal, fascia, or ligament. Also, we can do some resection, the star, the TST, etc. But it's compromising from my experience. For a cluster of symptoms, actually recently we do like transvaginal uterus sacral ligament and fascia and the perineal body plication. That's from the 3 level to do this repair. That's from the Dr. Petro's integral theory thinking. Till now, I have only 12 patients experience. The short-term results is very good for these patients, and the long-term results, that's 2-year long-term results. Some of the patients is not very good because with the long-term, the ligament is still loose, so it need after the operation still need like biofeedback therapy. That's quite good. Otherwise, we can also do the ventral rectopexy, the sacral nerve modulation, and the sling procedure. But the sling procedure, like the TFS, the tissue fixation system, that's not in our country market. And as for the customized surgery, still a long way to go because no consensus. And also the pathology factors has many reasons. And the outcomes varies in short and long term. Also the surgeon's training and experience, complications, etc. we need to consideration. Also the patient's expectation and how can they affordable some like very expensive things like sacral nerve modulation nowadays we can do, but nearly no patient want to choose the sacral nerve modulation in China now in constipation, ODS. And for the like selective candidates of the ODS, that's less than 10%. Otherwise, it is difficult to predict the efficacy. So we need to have a very good, like conservative treatment before the operation, and after the operation, we still can do the conservative treatment. So we will have the multidisciplinary strategies. That's a mind, that's the idea to integrate the new health science data collecting and analysis, because we need rely on the big data in a real world to see, to evaluate what's the optimized choose for the ODS. Otherwise, we need the teamwork and the research. That's what's the best timing to do different methodology. And then we need the patient-reported health measurement to see that is this the best way for the patient? Is this the patient have the good compliance? Then we can get the personalized and the pressure and the precision medicine. These all need the integration. That's our mind idea. So take-home message: ODS is challenge for device etiology, and because we from the different from the integral theory, from gynecology, from colorectal, from the gastrointestinal brain-gut bacterial reflex. Also from rehabilitation field. So different subjects have different understanding of the ODS. So that's just a superficial. We need to pursue the integrated multidisciplinary point of individual leading techniques. And we also need the holistic concept of thinking to reach the consensus on the Oriental and the Western medicine. And we also need exchange and cooperate the international practice, optimize the clinical pathway. So, as for the ODS, it's very difficult to say that what's the best way to treat, because scientific question is always limited, but the humanity attention to the patient is always everlasting. So, if we have the good relationship with the doctors and the patients, it is not only like we give them the service, but we will have the agreement of the treatment, guidelines of the lifestyle. Thank you so much.
Thank you very much, Professor Shuqing. Now, we will not have any questions for this Keynote Lecture 3 as well. So we'll go straight to the next session 5. And our students will now say a few words.
Thank you for the insightful knowledge from the two precious keynote lectures.
Last but not least, session 5 is going to be anorectal surgery to pelvic floor disorders. Interesting cases will be discussed by our experts.
Please welcome our moderators, Emeritus Professor, founder of Colorectal Surgery Division of King Chulalongkorn Memorial Hospital, former president of APFCP, Professor Arun Rojanasakul, and our Professor Francis Seow-Choen. Please welcome both of them.
Can we have the panel up on the... Huh? Okay, the panel will sit in front. Those in front we consider as panel. You have the name here. Names are all there. Professor Jirawat, Patana Arun, followed by Professor Ting Shuqing and Professor Surilak Prapasivorakul and Dr. Pavesh Sheikh, Professor Roslani, and Professor Kasaya Taniplalachiva.
No, in this session is not question, it's case presentation, and the panel will discuss the cases. And I understand that pelvic floor is difficult to understand and difficult to approach, and so that's why we bring up many cases of pelvic floor for discussion. Okay, we start the first case. Who will be the first one? I don't know. Who's presenting? There are someone presenting. There are many presenters.
Okay, good afternoon. This case starts from Bamungrat International Hospital. Okay, so
this case from Singapore.
The story starts from five years ago. She is a female, 24 years old from Bangladesh, and 5 years ago she has the anal fissure present in Bamungrat Hospital and with anal pain and intermittent bleeding per rectum, and she has a constipation sense of incomplete evacuation and has to go to toilet many times to empty the stool around 16 to 18 times a day. And after she had bowel movement, she feels severe anal pain, and she has to use her finger to evacuate the stool. And sometimes she has to use the water hose to irrigation. She spent around 20 minutes in each toilet visit.
So we can stop here? Oh, okay. Next. Only
Okay.
history.
And her stool is described that it's soft, and she passed mucus sometimes. For physical examination, we found chronic anal fissure with white base, and the digital rectal examination we cannot do because of pain. This is all of the history and physical examination. So
In the panel, any panels to discuss what's next? What we want to investigation? Anyone want to investigation something? Okay. Or discussion the case. Okay.
Do we have any gynae history or obstetric history?
no,
Nothing.
she's, you mean obstetric?
Nulliparous.
She nulliparous.
Okay. And anything, any sort of childhood issues?
No.
After she was born, were there any issues? Did you contact?
We don't
with-
have history about that thing.
You don't have the history.
And is there any injury to her back, like that she has any back surgery, back pain?
No history of any trauma.
And did she remember why, when the first time the symptom occur? Is there anything that make her?
She doesn't mention anything about that.
Does she have some treatment about the fissure? After the fissure treatment, does she still have the symptoms?
Actually, this symptom started around 6 years ago, and she got many treatment in Bangladesh. Most of the treatment is only medical treatment. Never got any surgery for the anal fissure.
And this patient has some sexual issue, also have some psychological problem of the pelvic floor.
About that issue, I don't have the information.
Any other questions or any other questions you want to get from history?
Because the age, she's only 24. It's not very common to have a pelvic or obstructive defecation syndrome at such a young age normally in a nulliparous. I don't know. Is it common to have in this young age obstructive defecation syndrome? So probably it could have been triggered by the fissure. The fact that the fissure is there, that could have triggered off this. So you said that the examination was not done, but I think after applying some lidocaine jelly or something, it's usually possible to do. So at least we know the anal tone, and then further investigations to be done after that.
I would like to ask some questions about history. Why she used digitation, and when she did digitation, does she get some stool with the digitation?
Yes.
Professor Arun answered that question.
Yes. Sometimes he need digital evacuation and even water enema as well. Yes.
I want to pose a question to the panel. Okay. Now, the presenter said she has anal fissure and they did not do digital examination because of pain. I want to ask you a question. Then how can the patient do digital examination herself without pain? Now, first question. Secondly, if the patient can do digital examination, can the doctor not do digital examination as well? So that's a question I ask the panel.
I think I agree with you. Considering all this and the fact that she's this thing, That's what I said. You can always apply lidocaine jelly and do a rectal examination. That's always possible. You get a lot of information. You know the tone of the muscle, whether the spasm is there, whether other things.
So the first thing, I mean, this is as a moderator, I want to pose this to you and see whether you agree or what you want else to do. The first thing I think is that the fissure is a red herring, because the fissure may be there. They are probably, and we are not told whether this is they say this is acute chronic fissure, whitish base, but it may be just a consequence of her digging and because of her straining. So this is not the cause, but it's the effect. So I want to ask the panel whether you agree with this. If you don't agree with this, then what is your thinking? And also, what is the next thing you want to do for this patient?
So I just give my opinion. I think as Francis rightly said, when you digitally evacuate, you get that little fibrosis and the whitish color what you have. That is basically not because fissure. Usually we don't see a whitish base like thing. It's usually
you mean that this fissure come from repeat evacuation?
Yes. So it's basically a thickening of the anal mucosa, basically the whitening.
Oh, yeah. I give you more information because I see this patient. After that, she got anal fissure surgery in Bangladesh, not from our hospital. And then he come there later, is the wound healed. The fissure in that area has healed. So this should be a true fissure.
So it's basically a digital evacuation causing that fibrosis.
No, but even the fissure healed with fissure surgery doesn't mean it was a true or not a true fissure, because fissures, especially acute fissures, they still heal. And I think it's not easy to examine the patient if you don't actually part properly or you don't do a finger examination. If you're looking, sometimes there is some slough, as you say, or some mucus, and you can't really see whether it's a fissure or not a fissure clearly in the clinic if you don't do digital examination. That's right.
Okay. Next, what is the investigation you want to do? The panel, any investigation?
Actually, we need talk with the patient very carefully, because this is actually the patient maybe have some stress and anxiety. It's very common in China now recently, because she's young, but she still have more than 10 times for the defecation one day. That's actually from the psychiatric, we need have some evaluation for her. Yeah.
It means that the first time maybe some stool and the next time mucus, and mucus.
Maybe each of you can give what's the next investigation you want.
I would like to do her anal manometry actually. The first thing I would like to do is anal manometry.
So I think that the point is that if the patient has fissure or any pain in the anus, you should not put your finger in. And if now it's only here, you can do the complete digital rectal examination. So I will check if there is any mucosal lesion, and we can ask her to do the contraction. We measure the resting, squeezing pressure, and we ask her to push down and see whether there is an internal prolapse or any descent of the pelvic floor, anything inside.
Okay. April?
Just thinking laterally, I'd really like to make sure that this patient doesn't have something organic like Crohn's, coming from the Indian subcontinent, being a young female, presenting with a lot of these sort of nebulous GI symptoms. I'd want to rule out something like Crohn's.
For me, I need a manometry if possible, and then digital rectal examination. And then, if possible, I need some kind of difficography, because she presented with constipation, obstructification, and fissure. It seems like a typical fissure.
Dr. Tirilak, you haven't said anything. Very quiet.
Because from the history, she has the problem with obstructive defecation. Of course, there is a chronic anal fissure is the result of the obstructive defecation. So if she has no pain, and then per rectal examination will give you a lot of information about the paradoxical contraction, whether or not it's there. And another thing that we gonna do is the anorectal manometry, because it will give us a lot of information whether is there a Hirschsprung, which we can see later in the early adult, or is there any problems with the contraction of the muscles. And other things that we need to do is, because she passed the mucus, we need to do the colonoscopy to rule out any possible cause of inflammation or inflammatory bowel disease.
Actually, I want to give my opinion because this is Dr. Arun's patient, so he knows. You might not know, but you know everything. So this sort of patient, it comes to my practice. Actually, the situation started when she was 18 years old, right? So a lot of young girls, 18 years old, they want to be slim, they want to be beautiful, they go on a high fiber diet. This is the start of the problem. Honestly, I see so many of this. I don't belabor the point, but this is what happens. When they go on high fiber diet, they get big bulky stools, they start straining, and then they can't evacuate properly, and then they get mucosal prolapse, they get swelling in mucosa, and they get fissure, and this problem starting. You know, so often a very simple dietary questioning and what happened. And also what I do is, I agree with colonoscopy, but what I do is, I tell them, I give them bowel prep, I evacuate everything, I tell them go on a no fiber diet for 3 weeks. No fiber at all, no veggie, no fruits, no cereal. They take white bread, white rice, normal amount of meat. I see them in 3 weeks. If they are totally healed, then we know this is a problem. Then I say, from now onwards, take just a little bit or whatever you like, but don't take fiber. And then a lot of them are cured. I see so many of these, they are cured. Totally cured without any more investigation, without any more surgery.
Okay, next.
So Francis, are you inadvertently prescribing them a low FODMAPs diet?
Low what?
Low FODMAPs diet.
I see. To me, I tell all my patients, fiber is junk food. Because fiber you eat cannot be digested. So I explain to them carefully. I tell them go on an experiment for 3 weeks. That's what I do.
Okay, Francis always talk about the no fiber. And our practice, we use fiber. So in my practice, because he is my teacher, I believe him, but I still believe the book. So in my practice, I always say like this, and I always explain to the patients. Every patient responds differently. So you try high fiber diet. If it's good, continue. If it's not good, stop, and you try low fiber diet. If you do not eat any fiber and you are very good, then do not eat fiber anymore. So I told them that each patient respond differently. So I do not fix idea. I believe him, I believe in the literature. So I practice both.
I think I must say I agree with Francis, because all my patients, all these patients have been advised by so many people to have high fiber diet. And I just tell them, you just eat normal food, what everybody else is eating in the house, just eat that. Don't do anything else, just eat normal food. And I tell you, majority of the patients are much, much better with that.
Okay, never finished. It's a long story. Okay, you start with...
At that time, we sent a MRI difficultogram, and the picture is like this. Okay, you can say when she push and she relax, everything is doesn't move. And the radiologist interpret that she has the severe spastic pelvic floor syndrome and no pelvic floor relaxation. At that time, Professor Arun, he is the doctor that treat this patient. He suggests her to biofeedback first and water enema at that time. And the story after that, at the end of that year, she went to Singapore and Bangladesh. In Singapore, she got anal manometry, and the result was high resting anal pressure, rectal hypersensitivity, and rectal anal inhibitory reflex was present. Sigmoidoscope she got in Singapore too. They found that she has an ulcer at the distal rectum. And opinion from doctor in Singapore is etiology of this problem should be repeated intussusception of the rectum and have the trauma of the anterior wall of the rectum resulting in ulcer. And fissure may be due to repeated trauma from digitation or use of water hose. So in Singapore, he put the botulinum toxin at the internal sphincter. The total dose of botulinum toxin at that time is 50 units. After that, around few months, she went to Bangladesh, and at that time she got lateral internal sphincterotomy at the end of 2013. So after that, all of the history is missing, and she went back to Bamrunglan International Hospital again on June 2015, so around 2 years later. She still complained the same thing, still need finger evacuation, still pain after bowel movement. But at this time, for the rectal examination, there is no anal fissure anymore. And we found the gap of the internal sphincter from the sphincterotomy in Bangladesh.
Okay, we stop here. So from the investigation, maybe from manometry, from the MRI, any impression or any discussion from the panels?
So I think she will need biofeedback, basically. That can definitely help her.
So I think she is very young, and I think she should be asked and about her psychological. I agree with Dr. Ding that she has something inside her mind, because we found a lot of patients who repeatedly do the digitation by himself or herself, and finally, if we can make friends with them and then they can relax, that finally they don't need anything, they can go back to normal life. But now I think I would like to discuss a little about fiber. So usually I would ask the patient to make their stool form like Bristol stool scale type 4. So usually I don't ask them to eat the raw fiber, but I think they should do like the vegetable soup. So if the soup is already minced and blended, so it's easy to it make the bowel movement easier, and they absorb water together. And then maybe I will talk to the patient. Usually I do the manometry by myself, so I can have time to discuss with them. And also the biofeedback, she will see the same nurse every time, also may help.
Any other opinion?
I think the patient, the same opinion that we need to have the history of the, actually this kind of patients, very young, mostly from the psychological issues. Also, we need to have some history. Actually, the sexual abuse history, we need to know that's from the behaviors. So before the biofeedback, we need to know this. Then the biofeedback also need the cognitive therapy for the patient. Then the biofeedback, they will be good, because actually the high tone of the internal sphincter, it's from the psychological problems. If we do the Botox injection, that's only the first step.
But is the panel not worried about this? You see, I think there's two things here. One, we keep talking about psychological problems, but a patient has a solitary rectal ulcer, a big one. So, are we not going concerned about that? Because when that is there, you cannot give them biofeedback, expect it to heal. Also, you cannot tell a patient you got psychological problem, because there is something, there's an ulcer there, that's why she can't pass, and that's why she feels that she's got this problem. So first of all, my question is, Are you happy to just leave the ulcer and treat her with biofeedback and other treatment, or are you going to look at this ulcer? And if you are going to look at this ulcer, in what way are you going to look at this ulcer?
The big ulcer may caused by direct trauma by
No, it's
digitation.
very big. All round. It's not like
The
digital
second one, it may
trauma.
caused by puborectal spasm.
Yes. Likely to be. The solitary rectal, I think there are two possibilities. One from interception, the other one from obstructification, spastic levator ani, and then you can have big solitary rectal. It's shallow. It had been biopsy, and it's confirmed that it is a solitary rectal. So what's next?
Yeah, I want to just say a few things to the panel, and then you give you up. Because solitary rectal ulcer, when it's present, patients always have the feeling of tenesmus because they got swelling, they got pain, they got discharge, and they always feel very bad. So to tell the patients your psychological problem, it's actually unfair for them because they really have this problem. Now, secondly, these patients are well before the episode, and then they suddenly become worse and worse because they keep straining. Now, I'm not sure about, maybe the females know better. Any female that has cystitis, you can't control yourself. You say, don't want to go toilet, but you can't because the feeling is so strong. And these patients, they have this feeling, it's very strong. You tell them, hey, don't go, just control. They will die before they can control it. So I want to ask the panel. So I think, do we, at this time, the panel think it's more important to treat the solitary rectal ulcer or treat the psychological problem or just send a biofeedback? Or what's your next step?
I do agree with you because she has a history of solitary rectal ulcer. You have to need to look at it and do re-biopsy whether is it really solitary rectal ulcer. If there is a solitary rectal ulcer, you have to treat the solitary rectal ulcer. Either you give the succulfate enema to decrease the inflammation, and then give the stool laxative to help her to defecate better.
What kind of laxative?
Laxative, usually we give her bowel forming.
Bowel forming? I think this lady try every laxative, and not only one, and not simple one. He eat a lot of laxative every day, but cannot pass the stool.
But another choice is the retrograde colonic irrigation. Is the choice that to treat the distal obstruction.
She all have enema, cell enema. Yes, she do that. But even enema is difficult to pass out.
I want to ask another question. Okay, sorry for the panel. I want to ask a question. Now, we say the patient has solitary rectal ulcer. We say the patient has constipation, obstructed defecation. But we haven't asked, I want to ask you a question. Are you not interested to know whether this feeling of obstructed defecation is feeling, that means it's empty, but she feels it because it's ulcer, there's swelling, or is it because there's a lot of stool inside? Because the two things are quite different, and treating them is quite different. If the patient has solitary rectal ulcer and you put your finger in and you feel a lot of stools, that is stool. But if you put your finger in and you feel empty, which often is the case, then it's not stool. It is not stool. So if you give laxatives, you're aggravating the problem. If you give fiber, you're also aggravating the problem. But if it's full of stool, then there's a different story. So I just...
But we asked that question right at the beginning.
Yeah.
We asked when you put the
No.
finger in, is there
Yeah.
stools? We have already asked that question.
Francis is correct.
Stools.
Francis is correct. When they put the finger in, no stool.
And the manometry already showed that she has hypersensitivity because she feels something easy, like even it can be the represent of the solitary rectal ulcer. It is there that make it has cross inflammation and it makes her sensitive, or she may already have the underlying hypersensitivity that she try to push or I try to evacuate herself, and because now she has already did the MR difficography and it look very normal. Only spastic of the pelvic floor, and she already did the Botox. So now if I examine the patient and she already has the relaxed pelvic floor, and if I ask her to push down and it's normal, so I think I will do the local treatment like Dr. Silax said, do for rectal solitary rectal
Okay,
ulcer.
we all do that. But one interesting point is that Botox injection. I would like to ask the panel, with your experience about the Botox injection, how much you have to inject, which technique, how can you inject into the elevator, and in the puborectal, how can you put it, and how much, and the location which you inject. So panel, please.
As for the Botox injection, as from my experience, that's we need to use the EMG needles to guide. That's from the posterior, 3 points, posterior, 6 o'clock, 3 o'clock, 9 o'clock. Then we can test the needle EMG, we can test the paradoxical contraction. Then we the sound, the EMG sound is very very high. Then we can use this. The unit from China, that's a 100 unit for the 1 milliliter saline. Then so every point that's 0.3 milliliters.
I had only 3 cases, so I did bright technique. I used 100 unit of the Botox at 3 and 9 o'clock. So I did it in the operating theater, operating room under IV sedation.
In my experience, from what I train, we do under general anesthesia, and then we do 100 unit of Botox injection. We do it inject in the 3 o'clock and 9 o'clock. Before doing it, we do per rectal examination, that we palpate the puborectalis, and then we inject with
It's
the
mean blind.
needle. Yes,
It's
blind.
blind.
Yes.
I have never used Botox, so I have no experience.
Okay, you have any
Yeah,
experience?
the only thing I would add to that is that we would normally do our injections under ultrasound guidance. So I
You
would do
inject on
that.
ultrasound?
So you put in your endorectal ultrasound, and then your needle comes from outside, and you can actually see the tip of the needle.
Yes, from the
going-
ultrasound we
yeah.
can see clearly.
Yeah.
But in our practice, anyone inject with the ultrasound guide?
I think I have Dr. Chilawat case, we do it with ultrasound guide.
Right, very good. So we know that there are EMG needle and ultrasound guided. And for the location, I think you inject posteriorly, and the other one inject at 3 and 9. So what is the concept? What is the basic idea?
See, Botox, there has never been a consensus that exactly how much to inject, where to inject, even for a fissure, where exactly it should be injected, below the fissure bed or laterally in the intersphincteric space, or where. So there has been, everybody's got different.
I suggest that Botox is totally wrong treatment in this patient. Her problem is a solitary rectal ulcer, not the fissure. So injecting Botox is just a way of making money from her without treating her. Yeah.
But Francis, solitary rectal ulcer is a consequence, it's not the underlying cause. It's got to come from somewhere, and if she's constantly straining, she was normal before, right? Something started her off straining. So I have to say, I disagree with you. I think the SRUS is a consequence.
No, I actually don't agree with that. We always say solitary rectal ulcer is a consequence, but a lot of patients start with solitary rectal ulcer without any fissure, without any other problems. They start with solitary rectal ulcer, which is the main leading cause. To me, this patient needs treatment for solitary rectal ulcer first. If we can treat her, she'll be cured.
No, but I think those which occur on their own spontaneously, they're usually following interception. If they were interception, you can get a solitary rectal ulcer without any this thing. But in this case, there was no interception. So mostly solitary rectal ulcer could have come from digital evacuation.
For me, I will try to treat the solitary rectal ulcer first. And if she has no response, you have to look for the cause of the solitary rectal ulcer, whether there is a rectal intussusception or there is the anal anismus. MRI is just give, sometimes it's 20%. There is the wrong information about the rectal prolapse.
We discussed a lot, but at this time we don't know exactly what is or what are the causes of the solitary rectal ulcer.
Yes.
So we have only evidence that the MR difficultogram shows spasm.
Yes.
So we have any choices?
We do not know. Yes. Correct.
But you mentioned that she already take a lot of laxative. So I think we may have to look back into the colon. If her colon has already inert or she has something that caused the stool to delay and that she don't feel.
So we have only one case or more than this? More cases. I think we should move faster.
We have many cases, but maybe at least two. At least two. Okay. More,
Okay,
much
so
more.
For more information at that time, Professor Arun selects Keynote injection at the anal-coccygeal ligament, and 2 days later, everything is improved, decreased pain, and after defecation. And at the same year, 3 months later, on October 2015, she reported that, okay, there is some better outcome after previous injection. And she went back to get a further injection. At that time, Professor Arun chose a Botox injection. And
So Stop here.
Where was it injected exactly?
So you may ask question, why you inject steroid, and why you inject at coccygeal ligament somewhere over there? In fact, I think myself, because I have many cases, that maybe the spasm, maybe because of the inflammation of the fascia that override the levator ani. So I inject, in fact, I inject to the left hip, maybe inside, above the coccyx. I try to inject that area. With some improvement, after injection, she feel no pain at all, but still have some difficult defecation. And after that, she come back, and I inject Botox. I do not know where to inject at the time. I read many papers, but different outcome. So I inject Botox, but Botox very expensive. She do not have enough money. So I inject only 20 units. But my injection is different. I inject posteriorly, maybe the same as the Shuqing. I inject posteriorly because we understand that all the levator, especially the pubolactalis, attached to the coccyx. In fact, it's not attached, but if you pull the pubolactalis, the tension is at the coccyx. So I inject around the coccyx. I use only 20 units. The patient improved dramatically. She go back, she lived normal life without any smooth, without mucus. And when she come back, the ulcer healed, no ulcer anymore. That's what my outcome. The problem is, after a few months, the problem come back. That's the problem. We go next.
So after October 2015, she went back again 1 year later. She reported that the symptom disappear for 10 months and it's recur again. So at that time, her bowel movement around 20 times a day, still difficult to pass through, even loose stool, and more mucus. And same thing, she still need to use her finger to evacuation and use
Point proven. Right, this is the problem.
Yes, this is the problems. And at that time, okay, she got Botox injection again. And 2 days later, she feel better and the bowel movement decreased to 2 times a day.
The injection is blind. Again, it's not correct. It should be guided by EMG, yes. But I inject posteriorly near the insertion of the coccyx. I inject in that area.
And on November, she went back and she got the same treatment, Botox injection, and every time she will respond within 2 days. So this year, she came back on August of this year. She reported that everything still persists and severe anal pain, mucus discharge, still incomplete evacuation, still need the finger to evacuation. And per rectal examination, we found thickening of the anorectal ring. This time, we inject the Botox and advise about the puborectalis massage. This is the last visit in our hospital, and Professor Arun want to do something or any procedure to her, but she refused to get that procedure.
What about biofeedback? This patient, what about biofeedback?
She have the biofeedback before any treatment. She have that for a period of time, but no response at all. So this case is intractable spastic of the levator ani. And last time when I feel it, the puborectus, it feels thicker. It's soft. But it like a big and something, it's more muscle, something like that. But every time we inject Botox, she responds very well. But when we increase the Botox to 40 units one time, she feels very sick. I want to know what is the side effect of Botox injection. Do you have any side effect of the Botox injection? Do you have experience?
Side effect? No.
When we read in the
If
literature,
you've been injecting frequently, repeatedly,
when we read
obviously
in the
you have the
literature,
trauma of the injection
the
itself,
patient
so
may
you may get some
feel
fibrosis.
uncomfortable a few days, maybe sick, maybe fever, something like this.
From my experience, that only several patients have the second time to the Botox injection. Mostly they only once because they will have antibiotics from the Botox.
The Botox we can repeat often because Botox in China very cheap. The Botox here very expensive, especially in Bermuda, very expensive.
That's not the price. That's only the result. The results only once. That's okay.
No, I think this, first of all, the question I want to ask the panel, why do you think she recurred? Now, if she's well, she was well for 18 years, no problem. But now, why do you think she recurred? That's the question. Because we answer that question, we can prevent it from recurring.
I understand. In my understanding, I would like to speed up the case. I understand that with the Botox injection, the muscle paralyzed and it's getting better. But Botox lasts only maybe 1, 2 months or 3 months. Sometimes when the Botox lasts, the symptom again come back. That is my idea. Maybe it's not correct. But it's my thinking, my opinion.
My question is this: why do you think she recurred? I suggest. Again, I go back to the same basic point. You see, when she's well, she's passing 1 time a day. When the Botox, but she thinks, I got to make sure I don't pass. I don't have problems. So she's probably taking a lot of fiber. That's why problem recurs. It's a recurrent problem. I see this often. So when we get her well, she got to make sure her motion is small, little, less, so that she don't keep causing this problem. One way of preventing it.
Another thing which I do in some of the patients, I've started using Prochloropride along with PEG solution, PEG-based solution, because we don't want, if you give them bulk laxatives, you'll make the problem worse. Actually, the bulk is actually contraindicated for this type of problem. So Prochloropride with PEG-based this PEG solutions, they really help in evacuating them.
When we look at the literature, the last resort of treatment, the treatment of the spastic levator ani, is the excision or partial excision of the puborectalis. Anyone in the room have ever heard or ever see or ever practiced excision or incision of the levator ani? It doesn't work.
So about pelvic floor spasm, I have reviewed it come from stress and because if she has, you saw that when she go back to Bangladesh, she has stress, I think, maybe in her daily life. And every time she comes to Thailand, she feel better. And so she have to move.
Yeah. Prof. Arun has his own theory. Kasaya has her own theory. So we don't know exactly.
Okay, before we stop this case, go to the second case, I would like to add more information. I have another case, very similar, the same age, everything the same, almost the same. He even got subtotal colectomy, rectal anastomosis, improved only three months, and then come back, and then Botox injection, and then come back. And finally, I detached the levator from the coccyx. And now, she feels very good for 2 or 3 years now. She will get married next month. And this made the final conclusion for me that detach the levator from the coccyx is my solution for this type of patient.
And you do it through the perineum?
Oh, no. Detach it, only small incision at the coccyx. Very small incision and detach it, only local injection.
Yeah, through the perineum.
No, to the coccyx. Yes, very easy operation. The same patient, she just sent the mail to me. She will get married next month, and she thank you a lot for help her to solve her problem. Very, very interesting. There are 2 cases, but the last case, the case that respond do not have solitary rectal. I think we better go to the next case. It's time. What is the time?
5:20.
We have time?
Your coccyx, you're just making an incision there.
It's the case from the Syrian hospital. Is 46 years old Thai female. She has the history of difficult defecation for 3 years, but actually she has constipation for more than 10 years, and she's on regular use of the laxative. About 3 years after that, 3 years before come to the hospital, she has her symptom was worsened, and she complained about she has no urge to defecate, and she can open her bowels only once a week if she doesn't use any laxative, and she feels a little bit bulging at her rectum. She has a history of the incomplete evacuation, and also she digitated to ease defecation. Her stool was hard and a small palate, which is a Bristol stool type 1. She has no fecal incontinence or no urinary incontinence. Her underlying disease, she has no underlying disease. She's married. She got 3 pregnant and 2 abortion, and she used to use lots of laxatives, and mostly the Senna or Synacot that you know. And sometimes she increased the dose to about 8 tabs per day, and she feels that it doesn't help her symptoms. So she discontinued the drug for about 5 years, and she changed to use the detox, which is the rectal gate colonic irrigation with large amount of fluids, about 2 or 3 liters, and she used enema, and she has no history of the perineal surgery. Her physical examination, her abdomen was normal, and per rectal examination there is normal sensation and good anal sphincter pressure, and there is no paradoxical contraction when we ask the patient to strain, and we can palpate about 3 centimeters of anterior rectal seal, and there is no obvious pelvic descent. And At first, she come to the clinics, and we send labs, and all was normal. And what should we do next with these patients?
So panels.
What was the pharyngeal incision for? It was.
So her, may I have a look at a digital rectal examination again? She has the normal tone and no pathological conception. So usually in the case like this, with long time use of laxative and enema, we have to and no urge to defecate. So we have to evaluate her colonic transit time. Maybe with now we have colonic manometry, but the easiest one is the colonic transit study.
She has long history of constipation altogether with rectal seal. That means she has constipation with obstructification. So we have to investigate both sides, colonic transit time and difficultogram or MR difficultography. From our experience, from MR difficultography, we found that all cases of rectal seal have some kind of pelvic floor descent.
So any marker studies were done for slow transit constipation? It's been done, markers.
Yeah, we think she has two components.
Yeah,
she has
slow.
the chronic constipation with the obstructive defecation.
Syndrome. That's right.
Yeah. So we send her for the colonic transit time. In Sirat Hospital, we do the segmental colonic transit time. And the result on the 7th day is quite difficult to interpret, because in the morning of the X-ray, she feel very uncomfortable. Then she used the enema before the X-ray. So this is the result that we get.
No, but even enema, she still has a lot of markers remains.
Yeah.
So it means her really have a colonic inertia. But how for the pelvic floor evaluation, the basic investigation we use is the rectal manometry.
Yes, this is the retained marker. Then in the total colonic transit is about 98%, 98 hours, which is abnormal. And we do the rectal manometry, which is done by the gastroenterologist, and it was normal. And we also perform the difficultography because it's easy to perform, and for the MRI difficultography in Sirat Hospital is quite a long waiting time. And this is the difficultography.
So I think in like this, the from manometry, her defecation pattern is normal.
Yeah.
I see. And from difficultography, I think the rectal, she has anti-rectal seal, but I think she can empty it quite okay. So
from the difficultogram, it shown the large rectal seal and rectal anal intersubception.
From this patient, I think mostly that's a slow transit constipation. Actually, she has a rectal seal, but she has a normal term, normal rectal, a normal anal term. So we don't to treat this. So mostly that's because of the thinner. So we need to do the acupuncture and motility, something, urban medicine, yeah.
Yeah, and we found there is a large anterior rectal seal and also rectal intersections, which is quite a high grade because it's in the anal canal. And we do the colonoscopy as well, and it was normal. And what is the management of these patients? What would you do?
So I agree with Dr. Ding that her main problem is her colon slow transit. So usually I have to sit with her and ask her what if she really like to change her lifestyle back to no laxative. If like that, I will plan the daily diary with her, what she has to do, like what kind of fiber of food, water, exercise, and lifestyle, and which kind of laxative she can use. Usually I try to switch to another like new of magnesia, the stimulant, the other stimulant that may be not as strong as Senna, but it also help her to move the stool. At first it might be difficult, but I think if we can try treat the chronic inertia first, it should be good for her. If she not respond to medication, I think we have to pay more attention, like more investigation for her colon, like we may do the chronic manometry for her. Now we can do.
Basically, she has main component is the slow transit constipation, and the other component is this thing. But the manometry is showing that she's able to evacuate completely, even without, in spite of the intussusception and the rectocele, she's able to evacuate on manometry. So I think we need to just treat the slow transit constipation first and see how she does with that.
I would like to ask Kasaya and Dr. Ting, can obstructification syndrome cause delayed colonic transit time?
No. Obstructive defecation, they will go every day. In fact, several times every day. And slow transit.
From Chidawat question, then the next question is, if you have delay colonic transit time, and at the same time, you have obstructification with either cause, which problem you would like to attack first, the colon or the obstruction defecation? Which problem you would like to solve first?
Ask the
Pardon me?
patient which problem is bothering her more.
Pardon me?
Ask the patient which problem is bothering
No.
her more.
We should have some basic idea. With reason, we cannot ask the patient. We should have the reason how to manage this problem.
No, one of the things is this. Before the panel answer a question, I want to ask the panel, what is the incidence of rectal intussusception in normal patients? One question. Second question is, how many patients do you see with rectal intussusception that can pass motion normally? That's the second question. You know? The answer is actually a lot. A lot of normal people have rectal intussusception when you do a defecant proctogram. So this may or may not be a true problem that she's having. You know, so we blame it, but do we know what's normal? We don't know what's normal, you know.
I agree. The problem is, if you have difficult defecation with hidden interstitial and rectocele, and you solve this problem, with either, let's say, DROM or any others, they still improve the defecation. They improve. So, I understand you, that this can be in normal people. But in people who have this problem and have the symptom, we should pay attention to this problem.
If she had obstructive defecation also, like if the manometry is showing that she's able to evacuate, if the manometry shows that she's got paradoxical stimulation, contraction, then I would have said first do the biofeedback before correcting the constipation. But otherwise, if you in a situation where they have both the problems, then I think simultaneously they should be corrected. And the best option in this case would be to either do a ventral rectopexy, maybe a resection ventral rectopexy, something like that. So the constipation, at the same time you hitch up especially if she has a multiple If she has a multi-organ also symptom like uterine prolapse or a cyst seal, then I think abdominal surgery was the best option for her.
We ask presenter to continue.
Because she has two problems with constipation and also obstructive defecation, which from the evidence we know that there is a two part that we have to treat. And at first we do the conservative treatment first. We give her the laxative, we give her Pucalopry and see the response, and it was not that good because she was not respond to the Pucalopry. And we also advise her to do the rectal gate colonic irrigation, which she is very happy about it, because at least she can defecate and she doesn't feel any uncomfortable at her rectum. So, but we do conservative about a year, and then she feel her symptom getting worse. So we think which component should we fix, whether the constipation or the obstructive defecation, or we will do both in the same operation. That's what we think. And for her symptoms, it's mainly obstructive defecation. So we solve the obstructive defecation first. We do laparoscopic ventral rectopexy for that, and then see the response. And we did it for about 6 months, and her symptom improved, and she used very little laxative, and she can empty her rectum without defecation obstruction.
So I share you some ideas. Long ago, I think everyone know, long ago, I always comment that if you have obstruction, ODS, either cause of ODS, for quite a while, then you will have delay colonic transit time. And he said that if you have both problem, never attack the colon problem first, solve the ODS first. This is just Longo idea. I just share his idea to you. I do not know. I just tell what I know from him. That's all.
I share with you my idea. The colon is like a road. If there's a traffic jam, a narrowing, a road work, that's the point of problem. The traffic builds up behind it. The way is either you clear the jam, secondly, you don't add more traffic to the road. So again, the worst thing you can do is to add fiber, because you have add more cars, more traffic jam. Because you guys need to know this. I tell you, I see a lot of patients like this, and a lot of the 90% of them are cured by taking off fiber, because then they have less stool, smaller stool, less problem. 90%.
But I understand the technique to stop the fiber from my teacher. I think he stopped the fiber by breakfast and then no fiber. Okay. That's all?
Yes, that's all.
Thank you, Sirak. Thank you very much. We still have time, but do you want to stop? No. Jirawat? No? It's 20 minutes left. Okay, next. We have the next case.
Okay, this is the last case of today. She is a 68-year-old female presented with constipation and incomplete defecation. She has a history of prolonged episode on the toilet. She has polyuria about 10 times per day and also the nocturia 4 to 5 times per night. She did herself a colonic irrigation every 10 to 7 days. And her Wexner ODS score is 13 and modified Longo score is 14. This is a digital rectal examination, and we can see that on the left side, You can see that she has an anterectal seal and descent of all compartments. And the picture on the right side shows that she has a rectal prolapse with the enteral seal. She underwent the barium enema and showed the redundant sigmoid colon, and the colonoscopy revealed the internal hemorrhoid and melanocyst coli. This is an MR difficography. When she defecates, you can see that all three compartments are sliding down. And this is the result of the MR difficography. She has moderate widening of the urogenital hiatus with severe pelvic floor descent during defecation. She has moderate cystocele, severe peritoneal seal and enteral seal, and also uterovaginal prolapse. And for the rectum part, she has anterorectal seal and full thickness rectal anal intersubception with small rectal prolapse. So this is for the panels for this discuss of the management.
Before we start, I have one question first. If outside the hospital, maybe in other hospital, they do not have the MR difficulty, and they do not have either the difficography. So in those conditions, in that condition, what will you do? Maybe I ask the panel. If without difficography, what will you do?
Refer them to a place where there is difficulty available.
That's the easiest.
Yeah, correct. And if it cannot refer, what will you do?
Send the patient there.
So you also don't have difficography, right? I think easy thing is you can do the transperineal ultrasound. You put the same probe as you do for the abdomen in the perineum, and then you study. So you can also see like this.
It's easier to do the difficulty than the perineal ultrasound because perineal ultrasound in Thailand maybe only 1 or 2 person who can perform it. Very, and I think in other countries it's not popular as well. Anyone do the perineal ultrasound here in our region? Maybe Shuqing one first, and from Songkhla, then we send many patients to to her. Okay, Chow, do you start perineal ultrasound? Yes, Chow, the other one. So very few. So you see, we have more difficult cam than the perineal ultrasound.
We can directly do the digital examination. We can directly do the digital examination from the rectum and from the vagina at the same time.
No, actually, the old-fashioned method, you can easily just give a follow-through, a gastrographin follow-through, and you put gastrographin in the rectum. Ask patients to strain. You can do what we call just screening, and you can see it. The radiologist can do it for you and just take pictures. You don't have to sit on a toilet bowl. They just put it. They can just strain. They can see.
I ask you what. Can you make a diagnosis of descent perineum without difficulty? Can you by clinical? I think you can. Just explain to me.
Yes. Okay, I changed my practice. For the rectal examination, I first take a look at the perineum descent or not. I ask the patient to strain on the left lateral position. If we saw the ballooning, that means there's some weakness of the levator muscle. In the more severe cases, the sphincter drop down after the ballooning. So, and during rectal examination, we can demonstrate the rectal seal, and then we open up the vagina. We can notice the movement of the cystocele or urethrocoele, and we can notice the movement of the uterus altogether. For the overt prolapse, we can diagnose it all, but in some hidden cases, we cannot come pretty sure.
It means that with clinical examination, you can tell that this patient had rectal prolapse with descent perineum or without descent perineum, with just clinical examination, and you do not need MRI. I think that's the message from Chirawat.
Agree.
Okay, next.
Actually, MRI is for study, and then it's a objective, not subjective evidence.
It's also medical legally important to document it, by MRI nowadays, because whatever surgery you do, if the results, we don't have 100% results in all cases. At least the patient can say you're not done the MRI, so how did you know whether this is there? So for medical legal purposes.
No. If the patient says that, you just say, send Dr. Arun to your expert witness, then you say no need.
No, they will not send to me because it's expensive. Not, I am very, very, very cheap. Arun very cheap, but the hospital is very expensive.
So as far as the management is concerned, since all the 3 compartments are involved, obviously all 3 will have to be fixed at the same time.
If we give the patient the operation, we should do the MRI or ultrasound because that's way we'll avoid the Sew.
Okay. Oh, wonder. Because I never think that, I never imagined that there are Sew in China too. Because it's different. Here we are very free to sue any person. But in China, maybe it's different, right? Do you still have can sue the doctor in China?
Yes.
Oh.
They don't just sue, they come and beat you up. Yeah. They beat you up. They come with knives and they come and kill you.
In India, doctors come under the Consumer Protection Act. We have a Consumer Protection Act, and the doctors also are taken in that, so they can file in the Consumer Protection Court. So it's very easy for them to do that. You don't require money to file a case. So coming to this management, all the 3 abdominal rectopexy, ventral rectopexy, we're hitching up the bladder and the vagina, the uterus in this case, I think would be the solution.
In this case, she tried Kegel exercise for 3 months, but the clinical does not improve. So we decided to perform the operation for her. The operation consists of four steps. We perform the abdominal cystopexy and colpopexy to correct the anterior and middle compartment. For the posterior compartment, we perform ventral rectopexy and closure of the deep cul-de-sac, and also the sigmoidectomy to correct the redundant sigmoid colon. This is a cystopexy. We mobilize the bladder and fix to the anterior abdominal wall. And this is a picture of the abdominal colpopexy. And the picture below is the schematic graphic of showing the fashion of the cystopexy and colpopexy. You can see that we fix in the different direction to allow the bladder to distend. The next step, we perform the ventral rectopexy. Because this case, we plan to perform the sigmoidectomy also, so we use the autologous tissue instead of the prosthetic mesh to fix the rectum. In this case, we harvest the tensor fascia lata from the lateral thigh and apply as in the same fashion with the mesh. The last step is to perform the sigmoidectomy. And this is the follow-up at 6 weeks. She still has some urethral hypermobility from the examination. And at 7 months, her clinical significantly improved. The polyuria decreased to 5 times per day, and nocturia only 1 to 2 times per night. And she has no more constipation, no more soiling, and no more organ prolapse. Physical examination revealed no wound complication, and in this case, we can avoid risk of mesh erosion. Her Wexner ODS score and modified Longo score significantly better. Thank you.
Thank you.
Okay, thank you very much. We have 10 minutes left. And any questions from the audience? Any questions from the audience? Any comment, Tiranut? Any?
I think like we have Alcohol Anonymous, we should have a ODS Anonymous for patients, where you make a patient group and then they can talk among themselves, vent out all their frustration among themselves.
You want to call the ODS patient to have a group to talk to one themselves. Their symptoms will multiply 1,000,000 times. They will learn from each other.
No, but the thing is that they will be also happy that they're not the only patient. They have so many other patients also with like that them.
Okay.
Who knows?
Each other. That's the last thing you want to do.
And any comment from the panels again? Okay. Okay. Thank you. The one who do the perineal ultrasound.
May I ask some question? I have one patient with lower rectal cancer, and now she is ongoing about perioperative chemoradiation, but she has rectal prolapse too. What should I do after this? Lower rectal cancer that need colorectal anastomosis and had a complete rectal prolapse.
Yes.
Resection rectopexy.
No. She asked that she need preoperative chemoradiation, but the prolapse still have the problem with the prolapse. Is that correct?
Yes.
Now she is on pessary during receive the chemo RT, but after this she refused the hysterectomy or something like that. She said that live with pessary is okay.
No. She needs an anterior resection.
For rectal cancer.
Yeah, the anterior resection will cure her rectal prolapse. Just do anterior resection, just leave it.
I agree.
and I think
this patient after the rectal resection, after the rectal resection, they have the patient has the prolapse, right?
No. Haven't resected.
Oh, okay.
Not resected yet.
Okay. I think the time is approaching, but I would like to stop here. And I would like to invite our dear speaker to stay with me here, and all the rest you can go back home now. Close.
Well,
For the general delegates, if you want to go to the gala dinner, please proceed to the pink elevator.